what I'm going to be talking about today, grounded in a patient case that we saw recently on our consult services around altered mental status and sort of considerations around alcohol use in that setting. And as you all likely already know, fairly common to use alcohol in the United States, fairly normally experienced. 80% of adults report some level of use over their lifetime. Binge use, about 25% of adults. So referring to use episodes that result in achieving the legal limit of 0.08% or more. So also quite common. And the sort of more dysfunctional levels of drinking are even quite common, with 10% of adults engaging in what's come to be called by the NIAAA, the National Institute on Alcohol Abuse and Alcoholism, high intensity drinking, or drinking on a daily basis 2 times or more. That binge drinking level that's concerning is that's associated with 7 times the likelihood of accessing emergency department and hospital care for issues related to that level of use. And around 10% of individuals in a given year will actually meet clinical criteria for a use disorder with alcohol or struggling with an addiction or use disorder. And as you might imagine, this has quite a significant impact nationally and globally. Alcohol represents the 3rd leading cause of preventable death, accounting for 7 million deaths. 3 million deaths annually globally, contributes to over 200 diseases and injury-related health conditions. And, a lot of times on our hospital service, we'll more be seeing sort of issues related to, heavy daily consumption and use disorder. But it's really this binge drinking category that contributes to the vast majority of healthcare related costs, as well as sort of indirect costs related to lost productivity and criminal justice and things along those lines. So the impact of those patterns of drinking are not to be underestimated. We pretty frequently have quite a multidisciplinary audience. So bear with me. I just want to make sure that individuals have a shared understanding around some of these definitions around alcohol use and what's thought of the NIAAA as lower risk levels of consumption. And so when we talk about a drink, it's important to have a sense of what we mean and give our patients some instruction about what we're talking about when we're talking about a drink or a standard drink. And you can see that depicted here, each of these containing roughly 14 grams of alcohol, 12-ounce beer, 8 ounces of your higher octane malt liquor, 5-ounce pour of wine, or 1.5 ounces of 80 proof spirits. These are the quantities that are considered a standard drink. There again, have about 14 grams of alcohol. And these are still what NIAAA is listing as the limits around lower risk consumption that you see vary depending on sex as well as age, with recommendation for women and for men over age 65 being 7 or less standard drinks per week, 4 or less on a particular occasion, being roughly, depending on the number of factors, but roughly the quantity that achieves that legal limit or greater. These guidelines differ for men under 65, where the recommendation on cutoffs for lower risk consumption being 14 standard drinks or less per week, and 5 drinks or less on any occasion. And so these are still what's out there by way of the NIAAA guidelines. But as many of you may know, there's getting to be more information out there indicating that even these lower levels of consumption when undertaken on a daily basis, may still confer some risk in terms of some health conditions, with primary examples being breast cancer. And there also being some evidence around impact on certain aspects of cognition among older adults. In one of the most widely cited studies of 2017, the BMJ large population-based study, there appeared to be statistically significant impact with these low risk levels of consumption on lexical fluency or word forming. When people sort of regular days. So there may be reason for us to be thinking more, be more mindful, around our counseling when it comes to alcohol consumption, depending on, say, family history, some of those issues, and of course other comorbidities that might impact this counseling. Where there are also some groups where we generally would recommend complete abstinence, for example, liver disease, pregnancy, or some things like those. So there's some nuance. So with that, by way of some information that may be helpful as I run through this case, I want to talk about, I dug deep into an arcane cinematic and theater reference for the pseudonym here, and Mr. Clay. Anyone picks up on that and can name the movie or the actor, I'm impressed. He's a 35-year-old male, and he was brought to the emergency room after an episode during the course of an ophthalmology visit. After a dilated exam, he had a witnessed 30-second seizure-like episode with stiffening, cyanosis, and altered mental status, and had a second episode after being taken to a bench in the clinic a few minutes later. And so was transferred to the emergency department for further care, where he had a third generalized episode involving eye twitching, jaw clenching, global tension, and blood was seen to be in his mouth, and a small laceration on his tongue afterwards. On recovering from that event, he was oriented, but presenting as quite anxious and tremulous. And he received a dose of lorazepam at that time, thinking he was having an alcohol withdrawal related seizure. He had previously been diagnosed as having a seizure disorder that at the time was thought not to be alcohol related. As his reports around his alcohol use during the course of these outpatient evaluations were consistently in that lower risk range. 2 to 3 standard drinks on 2 to 3 occasions per week had been his fairly consistent report at the time. And so providers also were concerned, given that information, that his ALT and his AST and ALT were fairly consistently elevated. And so he'd been undergoing a workup for that, including for autoimmune disease, ceruloplasmin, and the like, that so far had been turning up negative. He presented as someone that was fairly functional, had his own apartment. He did live alone, so getting some corroborating information around his alcohol use reports was a bit of a challenge. His mother didn't seem to feel like she had encounters with him, and she felt like the amount of his consumption was a concern. She incidentally was present with him during his ophthalmology clinic visit. By all reports, he'd been functioning well. His vocation as an electrician, and during sort of lucid moments in his emergency department course, he had this, again, fairly consistent report around his alcohol use, perhaps somewhat larger than what I'd seen in past outpatient visits, 3 to 5 drinks on about 2 days each week. And he denied any other illicit substance use or prescription substance use. You can see some of the pertinent aspects of his initial physical exam here, including mildly elevated temperature, heart rate, blood pressure. After his episode in the emergency department, then he was oriented, but his speech was fairly slow, tangential occasionally. He was noted to have tremor in his upper extremities. I made mention of the laceration on his tongue. Affect was appropriate. Speech and thought processes were somewhat tangential, and Stu provided this example. When he was asked about urine and transposed words, urine, and some similar things during the course of the review. So far as pertinent laboratory data, his blood alcohol concentration was positive, but below the limit of 0.02. Magnesium was mildly low. Other electrolytes within normal limits. His LFT elevation was fairly consistent, reported on outpatient tests. You can see his bilirubin there. Normal is albumin low, similarly. We have a fairly significantly elevated cell volume and thrombocytopenia, platelets of 99,000 there. His coagulation studies were normal, and imaging undertaken at the time were also that. So, before we start getting the further details around his case and sort of thinking about it and what transpired after this event in the emergency department, a little bit more by way of background around alcohol withdrawal. It is something experienced by about half of individuals over the course of a year. The criteria for alcohol use disorder and what causes that. To simplify things, some alcohol is a central nervous system depressant operating through the GABA, the primary inhibitory central nervous system set of pathways. And so with repeated exposure, that GABA system down regulates. If the alcohol then is withdrawn, there's this relatively unopposed excitatory central activity that explains a lot of what we see, particularly with early stage 1 withdrawal, where they'll present as anxious, tremulousness, and continuing to try to abstain. They have periods of difficulty sleeping. We see elevations in heart rate, blood pressure, temperature, and often respiratory rate. And these early symptoms, typically it'll present 8 hours or less after their last consumption. Most typically will peak between day 2 and day 3, and generally resolves by the time we get into day 5 to day 7. But this wouldn't be a very exciting case if that's what happened here. This is what many of you likely are already familiar with, the CEWA scale, the Clinical Institute's withdrawal assessment. And so far as the evidence base goes, treating early or the stage 1 alcohol withdrawal, that autonomic activation, in a way that's symptom guided, provides effective relief and also improves outcomes such as duration of hospitalization and the overall dose of a benzodiazepine that's given. And so you can see the basic framework used to assess the severity here, checking in with the patient around symptoms like nausea and vomiting, observing for tremor, observing for sweat on the skin, inquiring around anxiety, tactile disturbances or tactile hallucinations, auditory, visual, and asking the patient about headache. So, and then you can see at our institution, based on that score, that guides the dose of, in our case, most commonly lorazepam that's given in an effort to alleviate these symptoms. The thing that you may note here, as we're getting to be talking about altered mental status, is there are a number of these items that require the patient to be able to answer a question. And so the CWA score can become a little bit of a challenge, as a patient is becoming delirious, as their mental status is altered, particularly, inquiring around tactile disturbances, inquiring around headache, where I have those red arrows, where it seems a dubious proposition that we'd be able to assess those sorts of things accurately. Some of the other things with the yellow arrows, there may be some observation that the nursing, other staff can do to gain some sense of how they might score that. As I think you can also see, there are going to be circumstances in patients that are more dramatically altered where that's going to be a real challenge to sort out. So far as Mr. Clay goes, as you might imagine, things progressed beyond that mild disorientation, tremulousness, anxiety. His orientation began to wax and wane. Interestingly, a lot of the day, rather than agitated, anxious, he seemed to be drowsy. And that fluctuated with these more alert, agitated periods, with CWA scores getting as high as 25 over that first night. Then further on, despite the indicated dosing of lorazepam, was still having these elevated CWA scores beyond 20, where at our institution now triggered consideration of shifting from the benzodiazepine to phenobarbital. And so that was undertaken with the patient continued to be agitated, restless, interfering with pairs and removing lines. And so then he was again notified at that point, and the continuous infusion of lorazepam was initiated. Some relief, but it's nursing noting more dramatic relief after antipsychotic haloperidol was delivered. And so I'm going to show you, we have a view in our system where you can kind of see how the CWA scores are trending. And so here you can see kind of early after his presentation where his CWA scores were getting to that 25 range, and he'd received that 7 milligrams of lorazepam, and then a further overnight 16 milligrams of lorazepam for 23 milligrams total. And I draw your attention to this because I think folks can feel pretty nervous about the kinds of doses of benzodiazepines that are often required in individuals that are progressing into more severe withdrawal states. But this is not at all unusual. So just draw attention to that, by way of indicating that, providing those symptom-triggered doses is really sort of what's indicated and what we know is most likely to alleviate those symptoms and avert progression to more complicated withdrawal states for applicable particular dose, right? So then you can see the administration. So here where you see lorazepam dosing not happening over an 8-hour course or so was where the lorazepam infusion was actually initiated. at 1 milligram an hour. Didn't really exceed that. You get to sort of more supplemental razapam doses, as well as the phenobarbital dosing, which here normally the initial bolus is 260 milligrams IV, and then that can be followed by 130 milligrams every 30 minutes thereafter for a CETL score that continues to be greater than 15. So when this is fairly uncommon, even among folks with alcohol use disorder, but complicated alcohol withdrawal does develop in 3 to 5% of individuals that meet criteria for an alcohol use disorder. Typically, onset is around 3 days, getting these more severe withdrawal states. And some of our addiction medicine textbooks will tell you that the range is from 1 to 8 days. I think others that are out there that see alcohol withdrawal would also say that, boy, we've seen this go on for a couple, 3 weeks at times. So if that does happen, while unusual, it is not outside the realm of possibility to see more complicated withdrawal states with that sort of duration. And you can see beyond that, the agitation, sometimes combativeness that you can see. We normally also expect to see that autonomic hyperactivity. So that elevated heart rate, elevated blood pressure, and if we're seeing that agitated delirium in the absence of those things, sometimes calls to question, is it really alcohol withdrawal that's doing that? Or is perhaps the patient receiving, a beta blocker or something along those lines that might interfere with those expected autonomic manifestations, the tremulousness, the tachycardia, the hypertension, things along those lines. The attentional disturbance, for some of the other states, altered mental states that we'll see, a lot of times a patient may be able to track us fairly well with this agitated withdrawal delirium. That's more often less the case, and important to realize it's happening when it's happening, because it does carry a fairly significant mortality rate if it's left untreated. So one of the questions that we'll pretty frequently get on the consult services, how do I know if a patient that's using alcohol heavily daily might progress to something like this? And I got to say, we don't know entirely. The primary factor that might make us think about that is if they've had these episodes before. And I think that's something to take note of. If it's a patient who's presented to your institution before and had these complicated courses of withdrawal, trying to do a little digging and seeing what they've responded best to with those previous admissions. Did they do okay with the symptom triggered protocol? Or did they respond better to the phenobarbital regimen or a different benzodiazepine, perhaps a scheduled diazepam or something like that? And really, that's tended to be, our approach is that clinically individualized approach. And I think this is, an area where we tend to see, a lot of variation in practice and how people approach altered mental status when the thinking is that it's an alcohol withdrawal delirium, and that's because I think we don't really have optimal scientific evidence to guide what we do particularly there. But Majid, I wonder if you might want to throw in there, as you see folks like that coming into the ICU here, if there's kind of a different approach to that, if you do have kind of a standardized, okay, this is someone with alcohol withdrawal delirium, and that you and your colleagues approach it in this particular way.
Yeah, no, it's I think if they're coming to ICU, right, it's usually more severe, complicated problems. So it's pretty apparent at that point. I think the bigger question is who are the people that are going to kind of get to that point before they were being called for an ICU transfer. And the problem with some of these, I mean, I think the strongest predictor is someone who's had a history, right? What predicts the next event is someone that's had that event in the past. So some of these complications of delirium and DT and seizures are probably the strongest of these. The lab stuff is hard to make sense of, especially the challenges that we have in ICU where it can be a mixed delirium picture and it's hard to know what's the underlying etiology. I mean, if they came in for frank alcohol intoxication and having a primary diagnosis related to their substance use, that's one thing. But if they're coming in because of complications from their alcohol drinking, which is, physical ailments that are more commonplace, sometimes it's a confounded picture. And so laboratory, I think values are confounded, and the literature on these are small observational studies with like thrombocytopenia and things like that. And so they haven't really been well validated. There's also like the PAUSE, which is Jose Maldonado's score for predicting alcohol withdrawal syndrome, and that requires self-report within it, and their VAC has some role there. But for the most part, it's really kind of a combination of multifactorial approach that's for that individual, and I don't think there's been a good approach to anticipate these problems prior to needing ICU care that I've seen in terms of a more objective prediction.
Right, thanks. Appreciate it. One thing I point out here by way of not necessarily that it has outstanding value as a predictor, but the group of older adults and younger individuals will generally anticipate that they'll present with those autonomic manifestations of withdrawal before progressing to these more complicated or these more severe withdrawal states. But it's not uncommon for older adults to present initially with altered mental status without those autonomic manifestations. And so that's something to have an eye to. One of the other potential predictors that's been, let's get slow there. Yeah, one of the other potential markers that's been put out there, but again, as Dr. Afshar pointed out, none of this is 100% with outstanding positive predictive value. But one thing we'll have an eye to will be blood alcohol level at the time of presentation. And if they've had prior presentations with these highly elevated blood alcohol levels. So generally in someone who's fairly alcohol naive or has previously been drinking at a lower risk level, you'll expect blood alcohol levels greater than 300 milligram percent or 0.3 as a lab tends to report it being fairly somnolent, if not in a coma, and where we see an individual who's achieving blood alcohol levels 0.4, 0.5, even that we've seen and still been fairly alert and conversant. There's been some conjecture that those might be individuals that higher tolerance, greater risk for progressing to these more complicated withdrawal states. But again, far from a perfect group. And I think the other important thing to keep in mind is we interact with patients who may have some level of regular alcohol consumption. Is individuals who are drinking alcohol at unhealthy levels, yes, they are at risk for alcohol withdrawal delirium, but they're also at risk for the host of other potential causes of altered mental status. And, as a hospitalization goes on, in particular, that can become a little confusing by way of, boy, is this alteration still alcohol withdrawal delirium, or is the lorazepam or the phenobarbital, or what have you, that they've been receiving, making the situation worse rather than better now? And that can be confusing to BART sometimes. They're also at greater risk for different forms of infection that can create this alteration, metabolic disturbances, low perfusion states such as shock, heart failure, um, post-operative circumstances, particularly for older adults, confer risk for altered mental status as well. As we're getting to these more advanced withdrawal states and in the setting where you are indeed, ICU delirium, interested to hear, if you feel like, oh yeah, there are ways I can kind of tease that apart as far as ICU delirium versus alcohol withdrawal delirium, distributed resistance.
Yeah, it's hard. I think we have validated screening tools to assess for delirium. We use the CAM-ICU, the confusion assessment management tool that was developed out of Vanderbilt, and that has a sensitivity and specificity above 95%. But discriminating between the type of delirium is, I think I'm challenged by that constantly. I mean, it could be both. It could be one or the other. I'm not sure. I think this is one of our more challenging issues we deal with, and especially within the spectrum of delirium, we have a lot of folks with hypoactive versus hyperactive delirium. But certainly amongst the hyperactive delirium folks, it's difficult to differentiate between alcohol withdrawal from sepsis and other types of encephalopathy that are common in the ICU.
Yeah, back when today's speaker was not a full professor, but was a fellow hanging out at New Start with me, we certainly saw a lot of these cases in the intermediate care unit on continuous infusions. And in general, the New Start service, when I was there, used higher doses than you'd see a lot of other people use. We really tried to keep people really stable. And, it took a while to get the staff not to be stunned at the dosage levels, but 120 of Valium was not that unusual, which would be 24 of lorazepam in a day. I had some cases where I was using IV Valium, which you have to use in a push format, of getting over 1,000 milligrams a day. I think that was when I was in Eau Claire. So some of these people need very high doses. And there's been a lot of people trying in the literature in the last few years about predicting. And the best article I saw in the last few years really said nothing is going to predict this except past experience. No algorithms of lab results or liver failure or electrolyte disturbance or anything else. And I would really argue against using any of the blood alcohol level things as a predictor of what you're going to do. They certainly can tell you the level of tolerance somebody has. And so obviously somebody riding their bicycle to the emergency department with a BAC of 450 has a huge amount of tolerance. But I've been asked to consult in situations where a unit has developed a protocol and they use BACs as a deciding factor. And I've never been warm to those, especially a BAC above a certain amount can't come to a psych unit. I've seen that sort of thing in various hospitals. In general, that BAC will tell you something about their tolerance, but won't necessarily predict the withdrawal they're going to experience. And Randy's absolutely right about some of these people not really presenting with the classic autonomic hyperactive states. So if somebody has a history of this, not using symptom triggered, but actually just giving them some sedative, I think is safer. And if they have a withdrawal seizure, Randy talked about old patients presenting with mental status changes as their first presentation. That, of course, can be the case. But people who are not over 65 at all, it is unfortunate that some people present with a seizure or present with delirium without showing signs of the autonomic stuff or the hallucinosis first. And my rule of thumb has always been, if they have a withdrawal seizure during this episode, that's a kind of ominous thing. They're at great risk for further, because multiple seizures certainly are common in this population. So when they have a seizure, I generally will go in with sedatives, regardless of the CWA score. Give them some replacement. They obviously were missing sedative enough to have a seizure, for Christ's sake. So they do have a sedative lack. And giving them stuff, again, just because, giving them really in the range of 80 of Valium is a good idea. Giving lorazepam can be really good, but if it's not dosed frequently enough, you'll lose the patient, they'll get worse on you. When they do have reasons not to take diazepam because of liver or respiratory issues, then you're sort of stuck with the short acting. I have seen toxidromes, as Randy pointed out, from regular oral or IV lorazepam or something else. Most of the toxidromes are from IM benzos, which are not given very often. People have learned, don't give IM benzos. There have been protocols over the years that have called for that, and they're very damaging, because the drug doesn't get delivered quickly. It stays in the muscle, then the muscle releases it in an unpredictable way, and sometimes in very large amounts. And I've certainly seen delirium caused by IM. IV is generally pretty clean. You do have to keep it in your differential diagnosis that maybe the benzo is making them worse. And you determine that by just sort of looking at it. If more benzo made them worse, well, maybe you need to switch to a barbiturate. A lot of those things Randy showed about all the other causes of delirium. In general, any patient who is surgically or medically challenged is at more risk of withdrawal and more risk of withdrawal delirium. So the mixed states, car crash plus alcohol withdrawal, liver, kidney dysfunction plus alcohol withdrawal, it's going to make your withdrawal worse and actually make your need for sedatives greater. So you don't want to miss another cause of delirium, but at the same point, you don't want to fail to treat the alcohol withdrawal that's right in front of you. And I've seen people not treat the alcohol withdrawal because they're convinced that delirium is due to something else. In many of these cases, it's multifactorial, and you just have to deal with all of it. And stabilizing whatever's going on medically or surgically helps your management of the alcohol withdrawal part of it. But a lot of these people have both going on, and you just have to deal with both.
I think.
Sorry, go ahead.
Yeah, sorry, Randy. I think, Mike, those are great points, and I guess I would only want to add that in the ICU, people that get critically ill, and maybe in these mixed pictures, the evidence has really kind of gone in separate directions for how to manage delirium that's alcohol related versus non-alcohol related. And the non-alcohol related deliriums, in our case, which are mostly like septic encephalopathies and things like that, I mean, it's gotten to a point where we've now achieved grade 1 level evidence to not use benzos and avoid them at all costs, because they've been shown to increase mortality, increase length of stay, increase time on event, which is probably why you've seen kind of the practice change towards avoiding benzos and people not being comfortable with higher doses of benzos. But that's not to say that all these RCTs didn't excluded people with alcohol withdrawal, right? So we have a large we have a pretty high prevalence relative to other centers in the country. And so I'm continually challenged by trying to balance what is the differentiation between the types of delirium. If there is a component of alcohol, yeah, by all means, we should be treating that appropriately. But I'm hoping that we can figure out better pretest probability for getting our aside from just the prevalence of what we see, that can help us kind of give us a stronger likelihood ratio for what is alcohol delirium or alcohol withdrawal, and what's not, because there's potential harm that could be inflicted in these critically ill patients if it's not due to alcohol.
So I've just got up here some of the approaches that have some evidence guiding them around treating these more severe withdrawal states. Generally need to be undertaken, well, not all of them, but benzodiazepine infusion continuously. Here we've most frequently gone initially the lorazepam, propylene glycol vehicle. There's some increased risk for metabolic acidemia, and so generally we recommended if that hourly rate is exceeding 10 milligrams an hour, that consideration should be given to changing that agent. Example would be midazolam, whose vehicle doesn't suffer from that. And generally, if someone's progressed to alcohol withdrawal, delirium, I find it reassuring if this infusion has been titrated to a point where the patient is fairly somnolent. So they might be getting a little dozy during an interview, but they'll rouse to name or to light touch. And I feel like, and Mike, I think actually it was you that taught me that.
Right, exactly. The lightly sleeping, easily arousable. And I was on mute when Majid was talking. I was saying, Majid, if you do come up with a way to predict, it'll be a very frequently cited paper because it'll be the first one.
There you go.
I mean, nobody has figured out these predictors, and
I think you're right, Mike. I don't know if we can. That you bring up a great point. It's like I'm not convinced that we have the quality of data to do that, but I'm certainly trying.
So there can be some other modalities to consider. Again, agents that provide that seizure prophylaxis should be on board if alcohol withdrawal delirium is considered primary drivers of benzodiazepine or phenobarbital, and these things have been administered. Also, not important not to forget about the magnesium. I drew attention to that earlier. Benzodiazepines, due to magnesium's activity, the GABA receptor will be less effective if the patient has ongoing hypomagnesemia. So important to pay attention to that as well. Wernicke's encephalopathy, though it has a classic triad of nystagmus, altered mental status, phanoplegia, altered mental status, and ataxia. Only 33% of individuals that actually had that were presented that way. And so in the setting of altered mental status, heavy daily alcohol consumption, given the benign nature of higher dose thiamine to treat that empirically, we'll generally recommend just getting that going. For patients that are on receiving all of this, and still there are challenges that agitated delirium that's interfering with care, maybe putting the patient themselves at risk or others at risk. Adjunctive neuroleptics may be helpful, but again, aren't the primary therapeutic modality for the withdrawal syndrome. And there's also pretty good evidence around so that behavioral control for dexmedetomidine in humans now. And then all else failing, moving to propofol, may be indicated. Similar to phenobarbital, besides its impact on GABA facilitation, it also antagonizes excitatory glutamate in activity at the NMDA receptor. So it's sort of coming at this state from both of those angles. And Majid, have you in your setting ever used propofol in doses, where it doesn't necessarily require intubation, in this kind of setting, or generally it's alcohol withdrawal delirium and you're at this point, you're pretty well dedicating to ventilation?
You can dexmedetomidine you can give without intubating, and I've tried doing that sometimes as an adjunct therapy to avoid receiving mechanical ventilation. But if you start on propofol, you're kind of committing yourself to. But
Yeah, those are some of the things used fairly commonly. There are some other approaches with somewhat lesser evidence. Again, though, a lot of times we're talking about clinically individualized care based on what the patient has responded to during the current stay or previously. There have been symptom-driven protocols in ICU using the Minnesota detoxification scale to guide benzodiazepine dosing that relies less on those items that require patient response. That in this study used lorazepam doses of 2 to 8 milligrams as frequently as every 30 minutes. Alcohol withdrawal delirium, longer acting sedatives. Always important to have an eye to hepatic function in a population that's at risk for that to be an issue, since those are agents with active intermediate metabolites and long half-life, where setting a hepatic dysfunction may confer greater risk for respiratory depression. And something is used from time to time where hasn't been compared head to head with benzodiazepines, but is enteral ethanol or replacing alcohol itself, enteral administration. I've seen that some on our neurosurgical service here, with one of the tensions for them being they feel like benzodiazepines, more so than alcohol, really interfere with an important neurological exam to track the progress of the patient with a heavy brain.
So Randy, we can order ethanol in the hospital?
Enteral ethanol, yeah, through like NG is it's how I've seen it used. We don't have IV anymore. That went away some time ago, but there is, like a 95% ethanol that can be used for that.
Yeah, this is the part of the show where I jump up and down and start screaming, because there have been articles on this going back 30 years. Ethanol, and again, I'm not a cardiologist, I'm not an intensivist like Majid, but ethanol has the ability to cause cardiac irritability that the benzos don't have. And enteral alcohol, obviously,
hypertension and GI bleeding,
gastritis. I mean, just like we succeeded through QI approaches to get Demerol out of most formularies, getting ethanol out of hospital formularies actually, I think, should be a national QI project. I've seen, it's been ordered to slow labor, so OBs like to keep it on the list. But I just think any form of ethanol on a hospital formulary is very antiquated at this point, and I really do have concerns about this. And it basically is just sort of like people going to rehab in Florida to an 800 number. There's so lack of hope and such lack of confidence in treatment as usual that people reach outside the box. And I think looking for ethanol is because people are just still not comfortable with what we have available: gabapentin, benzos, propofol, barbiturates, the strong alpha agents like Precedex. And so they think, oh my God, this just isn't working. We have to think of something else. Let's think of ethanol. And I don't think it should be an option that people think about. And
given the adverse events, I think your point's really well taken. I simply point out that it's something that's out there.
I don't think it's anybody's guideline. It's in individual articles, but if anybody does analysis, I've never seen a guideline that says keep it as an option.
So again, as we get into these situations where patient is having ongoing altered mental status, what exactly is driving it? We need to start thinking about how to balance moving the plan forward, because there exists the possibility, again, that sedative hypnotics are contributing to a worsening or persistence of the situation. And so considering scaling agents back, reconsidering our differential diagnosis around what's driving the altered mental status, and considering other adjunctive agents to reduce the severity of the syndrome. So, by way of a couple pieces of follow-up on this patient that were interesting to me, before we close, is that, when he did come around and was interviewable, he again kind of related to me his 2 to 4 standard drinks consumption on a couple days a week without batting an eye and without hesitating. And so we added measurement of a phosphatidylethanol to a serum specimen that was drawn, I think it was house day 3 or 4. I've never seen a level this high, greater than 2,000 nanograms per milliliter. Made me wonder if there might be some possible other substance or metabolic abnormality that might interfere with that test. Our toxicologist here, Sarah Hackenmuller, who is wonderfully collegial and fielding my questions along these lines, was unable to find any such entity that interfered with this test. She did her own looking into the literature in contact with AREP laboratories to look into that, and actually a piece of information that made it look like he definitely was consuming more alcohol than he was reporting, was that over time during the course of his hospital stay, this phosphatidylethanol level did come down as distance from his last alcohol exposure increased. And this is getting to be a measure that we're looking to a little more as compared to some of the other indirect alcohol use biomarkers, as it has quite high sensitivity as well as specificity and area under the receiver operating curve in terms of its testing characteristics for heavy daily consumption with these cutoffs and statistics applying to greater than 4 standard drinks on a daily basis over the course of the 2 weeks. So we are at the top of our hour. I'm going to put up, and this will be available by recording as well, so you can get access. A lot of these references are sort of at the level of review. If you're interested in digging into those a little more. So I didn't burden this as much with some of the primary studies, but if folks are interested, get in touch with me around those. Before closing, I also wanted to make a note that Dr. Batnagar from the New Star program indicated that they are also using clonidine, oral plus patch in outpatient and inpatient settings as adjuncts with good success in the initial parts of withdrawal management as well. So